inviting me up, and thank you, Ganga. Also, I think Ganga actually designed this topic. It's a very difficult topic, I can tell you, because of the heterogeneity of the data and very difficult to interpret evidence. But let's try to do it, and let's try to look at how we can translate some of these evidence into practice. This is the outline of my presentation. I'll talk to you about how do we define treatment interruption. Then we'll look at few studies looking at the prevalence and risk factors for treatment interruption. We'll look in detail on the consequences of treatment interruption. And finally, we'll talk briefly about how to manage treatment interruptions and how to prevent them in practice. Well, there are two kinds of treatment interruptions, a planned treatment interruption and an unplanned treatment interruption. A planned treatment interruption would be a short-term treatment interruption, which usually goes on for days to weeks. And this is basically driven medically, either by the physician who wants to stop the medication of the patient for certain reasons. The commonest reason would be toxicity of a particular medication or a combination regimen. Conditions which would need nil by mouth, example surgery or pancreatitis, which is quite common in the HIV situation. Surgical procedures for the patient may be or may not be related to HIV. Drug-drug interactions which may hamper using these drugs together. You may have to briefly stop the medications. Pregnancy where you need to switch or stop, and especially delivery, around delivery time, if the patient is going through a C-section, you need to keep the patient NBM. And finally, strategically, if you want to really give a patient a breather kind of a thing to stop the medications on a weekend and take it for a week, and there is some evidence for this coming from the breather study. Very planned treatment interruptions can happen in the long term, but this is basically only in the context of clinical trials, particularly in primary HIV infection. Unplanned treatment interruptions are the second kind, where it's basically driven by the patient. You don't have control over it, and most common causes for these in low income settings like India, low and middle income settings like India, is affordability. Patients can't afford drugs, they stop it in between. There may be drug stockouts which happen in the government sector. There may be errors in prescription and errors in dispensing, particularly in inpatients, that we commonly see when nurses or they don't give the medications at the proper time. There may be treatment fatigue by the patient, particularly who is on a long-standing treatment. Again, toxicity driven by the patient because the patient feels can't tolerate the medicine. A lot of patients for intercurrent illness go to local physicians who advise them to stop the ART. So that is another unplanned treatment interruption. And then there are a host of other social and behavioral issues which cause treatment interruption, which are patient driven. The second issue is, let us see what is the prevalence of and risk factors for treatment interruption. Now there is heterogeneity of data here because people have different treatment interruption variedly. Some right from having a treatment interruption for 1 day to for more than 1 year. So this is something which is difficult. But this is one of the big studies, the ART-CCC, which basically looks at global cohort, kind of a global data collection cohort study, which looks at durability of first-line regimen. And as you see here, treatment interruption forms a significant proportion of, I can't find the pointer. Okay, treatment interruption is basically constituting almost 40% of non-durability of a first-line regimen, contributing to non-durability over a period of 3 years. So significant amount of people interrupt treatment and maybe reinitiate it later on a global level. There is a meta-analysis looking at risk factors and prevalence in low and middle income countries recently published. And again, this shows that around 25% of patients interrupt treatment unplanned for more than 3 months. And then there is a varied duration below less than 3 months. What are the predictors for treatment interruption? Younger age, people who are young tend to interrupt more, females interrupt more. People who come with advanced HIV disease, stage 3, 4 WHO, or a low CD4 count of less than 200 tend to have more unplanned treatment interruption. Let us now look at what are the consequences of treatment interruption. If you stop treatment, the first and most important thing is obviously going to be a viral rebound. You stop treatment, your virus comes up. that can lead to, in a significant proportion of patients, an acute retroviral syndrome, because you have a viremia coming up, so you have something like primary HIV infection, which can trigger retroviral syndrome, which is different from the seroconversion illness, because here you already have antibodies in the patient's plasma. If you have a long treatment interruption, then it's going to cause a decline in the CD4 counts, it's going to cause HIV disease progression, and then there's a whole lot of immune activation which is triggered by the virus coming up. So you have a lot of what are called as serious non-AIDS events. We'll look into the evidence for that, particularly cardiac events, renal hepatic, and the progression of neurologic disease as well because of the viremia. Obviously, since you are going to have viral rebound, the risk of transmission is there. We know antiretroviral therapy, if taken effectively, reduces the risk of transmission. If not, you would have an increased risk of transmission. And finally, of course, the development of drug resistance. And there are various factors really in treatment interruption which can lead or trigger to development of drug resistance. We'll see some evidence for that as well. Perhaps the most important study in treatment interruption has been the SMART study. This is an old study, almost a decade ago, where patients were randomized into two groups. This was a CD4-directed drug interruption study. You had a drug conservation arm in which patients continued to take antiretroviral treatment, and then you had a drug conservation arm in which the patient interrupted taking treatment based on CD4. So they started treatment and then they continued it until the CD4 went above 350, and then they stopped till it came to less than 250, versus patients who continued to take antiretroviral treatment. Now, if you stop antiretroviral drugs, you would expect that you are going to develop opportunistic infections and death from any cause, more commonly if in the drug conservation group. So it's not surprising that there was a significant, the trial was stopped in between because there was a significant increase in the risk of opportunistic disease and death in the patients who had CD4-directed treatment interruption as compared to continuous treatment. Now, you would also expect that if you stop antiretroviral medications, then the side effects of drugs like renal or hepatic or cardiovascular, for example, may go down. But this was not seen in the SMART study, and this was the major surprise from that study. In the drug conservation group, in the patients who interrupted treatment, you had a higher risk of developing non-AIDS events. So this was surprising, which triggered a thinking that it's actually HIV viremia which is causing immune activation, leading to higher event rates, and not solely because of the side effects of the medications. And then when you actually look at the risk ratios of these various events, the evidence clearly shows that it's the current CD4 and the viral load and not treatment interruption which is causing a higher risk of this event, both opportunistic disease as well as non-opportunistic disease. So when you stop treatment, a lower CD4 count and a higher viral load is going to trigger these events, and not just the treatment interruption arm as is shown in this slide. What about side effects? Because you think that you are going to conserve the drug in the interruption arm, you will get less adverse events. Well, this was not clearly shown in this study. There was a slight trend towards decreasing adverse events in the drug conservation group as compared to the suppression group, but then this was not really statistically significant. Now, this was something which was a clinical trial, but there was a cohort study from the EuroSID. Again, it's an old study which looked at the risk of progression to AIDS and death in patients who interrupted treatment for more than 3 months and then reinitiated treatment. And after reinitiating treatment, what were the events? And as you see here, even after reinitiating treatment, after an interruption of more than 3 months, you have a higher incidence risk ratio of developing an AIDS or a death. Which is shown in the first cartoon there. But then when you start adjusting it to the current CD4 count and the viral load, you see that that hazard ratio decreases. That means that after treatment interruption, whatever the CD4 and viral load is, that is something which determines the risk of developing AIDS or death. There's another planned treatment interruption, which was a PROMISE study, the third arm of the PROMISE study, which is basically a perinatal study which looked at continuing ART after pregnancy, after delivery versus stopping ART. And what they actually saw was not much difference in the AIDS-defining event, serious non-AIDS event, or death because of any cause between these two arms. It was quite safe, but then the study also showed that it is safe to continue antiretroviral treatment after delivery if you have originally only planned it to use for MTCT purposes. So very clearly continuing ART is something which is beneficial and safe even in the postpartum period. There were certain interesting things which were seen in the SMART study. I already told you the most interesting thing was a higher risk of developing CVS, renal, bone and liver toxicity. And what this was basically looked into was changes in procoagulant or inflammatory markers like interleukin 6 or D-dimer, which are basically procoagulant or inflammatory markers. And as you see here, the risk of developing higher levels of this increases with the risk of viral load on interruption. So higher the viral load, higher is the D-dimer, higher is the IL-6, as is shown in both of these graphs here. There's another trial which actually used a higher CD4 cutoff for reinitiating treatment, but however it also showed similar increase in CV risk factors with planned treatment interruption happening in patients who basically interrupted antiretroviral treatment. This is a recent Malawian study which looks at unplanned treatment interruption patients and looking at arterial stiffness as a surrogate marker for CV risk. And as you see here, as the number of treatment interruptions increase, arterial stiffness increases. The pulse wave velocity, which is basically a marker of arterial stiffness, increases over as the number of interruptions. So you may be able to reinitiate treatment, you may be able to reduce, achieve virologic suppression, but those treatment interruptions are kind of in the history of the patient, and that confers a higher risk of developing either an AIDS event or a non-AIDS event in HIV positive patients. So it's quite threatening to have treatment interruptions in your clinic patients. Interestingly, platelets also decline after planned treatment interruption. This is again data from the SMART study. And this is again basically looking at viral load. As higher the viral load, more is the decline in the platelets. What happens to the bone? If you stop antiretroviral therapy, the bone density improves. So that is directly perhaps more related to the, so this is one beneficial benefit of having a treatment interruption in terms of reduction, in terms of increase in the bone mineral density when a patient has a planned treatment interruption. What happens to sexual transmission? This is a study which looked at treatment interruption, correlation between viral and seminal viral load, and as you see here, as the blood plasma viral load increases, the seminal plasma viral load increases as well after treatment interruption, which is kind of a surrogate for increased risk of transmission. It's not only that, but the longer it takes for the viral load to go undetectable again, or for longer it takes to continue to be detectable, you have a higher risk of having a seminal plasma viral load leading to higher risk of transmission. It's also not dependent on what is the duration of treatment or adherence, but it also what type of ARV regimens you are using. This is a complicated slide, but what I want you to focus on is only the red dots. These are basically virologic failure dots, and this is an NNRTI. On the y-axis, you have the duration of treatment interruption, how many days a patient has interrupted versus average adherence on the x-axis. And as you see here for NNRTIs, if you have a longer duration of stopping the medication, the risk of developing resistance is higher, vis-a-vis for the same level of average adherence. But for a PI, you basically have lower average adherence, but not the duration of stopping a particular PI, which is leading to development of resistance. So it's not surprising that in the MSF study that you have patients resuppressing because their average adherence may have been good, though they may have stopped the medications for longer periods of time in their second line regimen. And finally, this is a planned treatment interruption. It's a success where you have young adults and adolescents being randomized into weekend off of efavirenz and continuing after achieving suppression. And as you see here, as compared to continuous treatment, the short cycle treatment did as well in these patients. So in very selected populations where you can monitor adherence, you can perhaps offer weekend off treatment with efavirenz based regimen. Let me briefly tell you about post-treatment controllers. This is not something which we do in clinical practice, but this is basically you start ART in patients who are acutely infected and then subsequently remove the ART. You plan a treatment interruptions and they achieve control without ART. And there are various reasons why you basically achieve this post-treatment controllers, right from reducing size of reservoirs to preserving gut-associated lymphatic tissue. But when do you start treatment? When is this most beneficial to achieve a post-treatment control status? Earlier is the better and not more than 6 months. How long before you interrupt treatment in primary HIV infection? You should perhaps treat them for a longer period of time, maybe for 3 to 4 years. And finally, what type of ARVs may also matter, because your ARVs initially should be able to penetrate into the gut and the lymphoid tissue where there is maximum amount of replication happening. So these are some of the factors which may help us in achieving a post-treatment controller if you plan to treat a patient with primary HIV infection. Let me finally end you by giving you, based on these evidence, how do we translate that into practice in terms of managing a treatment interruption. So if it's a planned treatment interruption, it is easy. If it's a patient is having a grade 4 event, a toxic epidermal necrolysis or a drug-induced liver injury, you need to stop all drugs. There is no issue about that. But if it is for a few days, in that situation, you need to look at what kind of regimen the patient is on and whether the individual ARVs have different half-lives. Particularly if it's an NNRTI, you know, they have a longer half-life, and if you stop all of them together, you're going to have functional monotherapy because of the long half-life of an NNRTI. So you can usually continue the backbone nucleoside for a period of 2 to 4 weeks, or you can replace the NNRTI with a boosted protease inhibitor for 4 weeks. You have to remember also that patients have food requirements. So if you have a patient coming out of pancreatitis who's on oral liquids only, or water only, then atazanavir, ritonavir absorption can be a problem. So you have to take these at the back of your mind when you manage these patients. In terms of planned long-term interruptions, I don't think we should do it or have a look at it outside the setting of clinical trials. This is just a cartoon which summarizes the differential half-life of NRTI and NNRTI. So this is a combination regimen of both. You see the NRTI dose going up, and then you have the long half-life of NNRTI. If you stop, then you're going to have functional monotherapy. So you continue the backbone nucleosides to cover for that functional monotherapy over a period of time. Now, managing unplanned treatment interruption, this is a clinical reality. Patients coming to you, if you ask them a history, they'll tell you that they have missed medications over a small period of time. So how do you approach them? In that situation, you have to remember that each patient is different, and there are various categories, various thought processes that you have to have in your mind in determining what regimen you are going to give. The key question here is, are you going to reinitiate the same regimen that the patient was taking, or are you going to switch the patient into, if he is on a first line, to a second line or a third line? And what is going to help us in that? First and most important is the nature of the unplanned treatment interruption. In that situation, what we are talking about is whether the patient took the treatment one day on, one day off, or whether the patient stopped all the medications together. In that situation, the risk of development of resistance is going to be high if they are going to be taking it intermittently versus somebody who has stopped all of them together. Again, you have to look at whether they're taking NNRTIs or PIs. And I told you that beautiful cartoon which showed you that average adherence make a difference in PIs, while how long the patient stopped the medication makes a difference in terms of developing resistance for NNRTIs. Whether it is a single tablet regimen that the patient was taking or a multiple tablet, whether he was going to stop only one component of a regimen and continue the second one. All of these things have to be taken into mind when you're deciding reinitiation or switch. What was the state of the patient at the interruption? Whether the patient was virologically suppressed prior to the treatment interruption. If the patient was suppressed, then the risk of developing resistance because of interruption is lower, and perhaps you may think of reinitiating the patient on the same regimen. What is the current clinical status of the patient? Whether the patient has advanced disease, in that situation, you can't really experiment by reinitiating the same regimen for the patient. Perhaps you should be switching the patient in that context if you're not really sure about the efficacy of reinitiating the regimen. Whatever you do, close monitoring, particularly after reinitiation, is very, very important. And that means you have to have access to viral loads. an earlier viral load to see a 2-log response over a period of 4 to 8 weeks is a reasonable surrogate that the regimen may be working fine for your patient. And finally, you need to also not forget to explore and address reasons for unplanned treatment interruptions. I'm sorry, I'm running out of time. So let me finish by giving you preventing issues. Most important thing obviously is medication taking behavior, and there are two concepts here. One is adherence to medication, another is what is called as persistence. That means you have to take a medication for a long period of time, and that is defined as persistence. You need both adherence as well as persistence for achieving treatment success. Unfortunately, there are very few interventions with good design which look at how to improve adherence to ART in the clinical setting. Large amount of evidence is available for SMS texting and reminding patients, and there are randomized trials which have shown the effectiveness of the same. And I think at this point of time, both in the public sector as well as in the private sector in India, adherence support system is a big unmet need, and that is something which we need to really look to improve in terms of reducing the risk of treatment interruptions. So let me summarize by saying that unplanned treatment interruption is a clinical reality. Almost all of us have faced this in our practice, patients coming to us with an unplanned treatment interruption. That is, it is very clear that even after reinitiating ART, these individuals have a higher risk of morbidity, mortality, risk of transmission, and development of resistance as compared to patients who continue to take treatment. Preventing unplanned treatment interruption is the key. Unfortunately, very few formally tested effective interventions are there. And finally, managing an unplanned treatment interruption in the clinic is a very complex process, and it has to be a highly individualized approach. And it's important to have access to viral load and close monitoring of the patient after reinitiating or switch to make sure that the patient resuppresses and gets a clinical benefit out of it. Thank you for your attention.